meet in consultation with a woman in her, let's say, mid-30s who comes in and she's just been diagnosed with fibroids, and a doctor has said, oh, these fibroids have grown very quickly, they may be cancer, I think you need a hysterectomy. And she is extremely distraught, and the problem is that she has seen someone who maybe wasn't as familiar with fibroids as someone who deals with them every day is. And so it is imperative that as patients, you see someone who's familiar with fibroids, who knows the various treatments, and will talk to you answering your questions so that the right treatment is identified. So what are fibroids exactly? That's always the first question. What are fibroids and why did I get them? So as I mentioned before, at least a third of women have them. They usually arise in the late 20s, 30s, and 40s. And although the fibroids remain after a woman enters menopause, because fibroids are nurtured by hormones made by the ovaries, estrogen and progesterone, they essentially stop growing in menopause and don't bother women once they arrive in menopause. They're the most common growth of the female reproductive tract by far. And African American women are more likely to have fibroids than women of other races and ethnicities. These are a genetically based condition. They're not caused by something that someone ate or exercise or a variety of things, but they run in families and we see them associated with certain races. That said, everyone can get fibroids. African American women have them more commonly, but this is an equal opportunity condition. Fibroids arise from the uterine muscle. The uterus is a muscle, just like your arm has muscles, your heart is a muscle. None of those muscle groups get tumors in them, but the uterine muscle, for reasons we don't completely understand, a rogue muscle cell begins to divide, make more copies of itself, produce a substance called collagen into the area around the fibroid cell, and then gradually a hard white ball develops, usually within the wall of the uterus, but I'll show you the different locations they can occur. There's tremendous variation in a fibroid condition. The fibroids could be numerous, as many as 30 fibroids. I've seen reports that describe innumerable fibroids. Sometimes women will just have one big fibroid, other times she'll have dozens of small fibroids. And they can be as small as a pea to as large as a cantaloupe. I mean, they can reach 18 centimeters in size. The important thing is that just the presence of fibroids alone is not a problem. The problem is when the fibroid causes the woman to have symptoms that then affect her quality of life. So here is an illustration of a uterus and fibroids of different location. So just to orient you to this picture, the uterus is in the middle here, and then the fallopian tubes are draped off to the side, and the ovaries are there on either side, and then these other masses are the fibroids. And so this would be a fibroid growing off the outside of the uterus, or a pedunculated fibroid. This is a fibroid growing inside the uterine cavity where the baby develops and where the menstrual lining sheds as a period. So they can be embedded in the wall, coming off the outside, or inside. And each location will be associated with different symptoms. So I'll show you a couple of actual photographs from operations. I hope they're not too graphic. But this is a uterus that has been removed as a hysterectomy, and it's been cut in half. So we're seeing one half of the uterus. This is the uterine wall. And here are two fibroids within the uterine cavity. And then these are fibroids more coming off the outside. And this is the ovary and the fallopian tube over here. But I draw your attention to this area here where this fibroid has pressed against the lining of the uterus almost like an ulceration. Fibroids that develop within the uterine cavity almost inevitably cause very heavy bleeding. So it's the analogy I think of is walking around with a pebble in your shoe. This is a hard mass within a very delicate vascular structure, and so fibroids in this inner mucosal layer cause heavy bleeding. Here's another illustration from an actual operation, just to orient you. Here's a nice normal uterus. Here's the fallopian tube coming off the outside, and the ovary, nice normal ovary. And here's a great big fibroid. This is probably about 10 centimeters in size, arising off the back of the uterus. And you can see that it's white in color. It has blood vessels on the surface of it. So this would be a subserosal fibroid. And in this location, it wouldn't cause heavy bleeding, but instead it's taking up so much space, pushing the uterus forward up against the bladder. So this woman would certainly have frequent urination. As soon as her bladder expands, it bumps into the uterus and the fibroid, and so she feels like she has a full bladder every hour or so. Here's a little collection of fibroids that have been removed at myomectomy, or removal of fibroid operations. And so again, the interesting feature is just how similar all the fibroids look. They're hard, white, rather rubbery masses. So I've mentioned a few of the symptoms that fibroids cause, but let's talk about them in more detail. Probably the most troublesome condition is heavy menstrual bleeding. These women typically continue to have regular menstrual cycles, but will have increasingly heavy and prolonged episodes of bleeding, perhaps even to the point of becoming anemic or needing blood transfusions. So every month their period is long and heavy. Some women can't even leave the house during the heaviest day of their period, or have to have a job where they can get to the bathroom every hour. So it can really affect their everyday activities. Then urinary symptoms are very common. Just as the uterus gets larger with fibroids, the pelvis is a fixed space, and if fibroids are taking up some of the space, and the bladder doesn't have room to expand. Also, women experience a sense of pelvic pressure or discomfort. And I'm specifically not using the word pain, because when someone comes in saying, I have terrible pain, it makes me think that there might be something else going on in addition to the fibroid. So it's more a sense of heaviness, pressure, discomfort. Sometimes women will develop discomfort with intercourse or back pain. Back pain's always a tricky one because there are so many reasons to have back pain that we have to be careful not to attribute back pain to fibroids, particularly if the fibroids aren't big enough to really be pushing against the muscles or nerves of the lower back. So again, just some of the terminology that you might see for the different locations of fibroids. Fibroids that are in the uterine cavity or pushing inward toward the uterine cavity are the troublemakers for heavy bleeding. Those that grow large outside the uterus press against the bladder, take up space in the pelvis, and give more of those what we call bulk symptoms. So how does a woman know that she has fibroids? Many times women don't know they have fibroids until they go in for a routine pap smear annual exam, and they can be diagnosed on a routine pelvic exam. So the healthcare provider typically puts 2 fingers in the vagina and then with the other hand presses down on the abdomen And in this way, the uterus is almost trapped in between the two hands. That's what your healthcare provider is doing. And you can feel when the uterus is enlarged. Usually the uterus is about the size of a fist. So if you've got an orange coming off the backside of that fist, that's something that can be felt. If the uterus feels enlarged, then typically an ultrasound will be ordered to confirm what is making the uterus larger. And ultrasounds are done two ways, either through the lower abdomen. Typically, a woman has a full bladder, which gives a little window to see through, and the ultrasound waves go in through the skin, bounce off the structures inside, like the uterus, and give a picture. And then also a vaginal probe can be placed in the vagina, and that also gives very detailed views of the uterus. Now, you really need to be skillful at reading these, because this is what a radiologist or a gynecologist sees at an ultrasound, and it's very subtle. So this area here that is whiter in color is differentiated from this area because this fibroid is denser, and so it blocks more sound waves. But ultrasounds can be tricky to read unless one is experienced at reading them. But ultrasound is the mainstay of diagnosing fibroids. In certain circumstances, we want extra information in the form of an MRI. And here is what a large fibroid looks like on an MRI. You can see it quite clearly. Just look at this poor little bladder down here being squished by the fibroid. Usually this bladder can expand up here, but instead it bumps into this big hard mass, and this woman would have frequent urination and urgency, and probably has to get up a few times a night to use the restroom. So now really the crux of fibroid management is to decide when a person needs treatment and when she doesn't. And the take-home message is that first and foremost, fibroids need to be treated if they're causing symptoms. So a woman who has fibroids, they're present, but they don't bother her, does not need to have treatment. Remember, these are not cancer. They don't turn into cancer. They don't damage nearby organs. The bladder may not have very much room to expand, but it isn't actually damaging the bladder, for example. So the first thing that I explore with patients is what her symptoms are and how much they're affecting her quality of life. I've seen women with great big fibroids, like she's 5 months pregnant, but they don't bother her, and I say, then we won't do any treatment at this time. Our treatment options, as you'll see in a minute, are fairly invasive. I want my treatment to make her better. If she's doing okay, I can't make her better, and that's my guiding principle. That said, there are going to be many women who do have symptoms, and we'll talk about the treatment options. So this chart gets a little bit busier every few years as more treatment options are added. We're going to start out by talking about whether there are medicines available for treating fibroids. That would certainly be the simplest. Is there a pill that we can take to shrink fibroids? What are the surgeries, and how do you do them, and how well do they work? Then for about the last 12 years, we've had uterine artery embolization. Actually, not 12 years. It's, about that, the late 90s. And then more recently, we're starting to get more data about something called MR-guided focused ultrasound. So I'll touch on that a bit too. So in terms of medical treatment, often a first-line agent is birth control pills for women who have heavy bleeding. Birth control pills, when used for contraception, have been known for years to make women's periods much lighter, shorter, and less painful. So they're an obvious choice in women who have heavy and prolonged bleeding. Now the problem is they don't necessarily work, because the problem leading to the heavy bleeding is the fibroids themselves, but we always like to try a medical treatment first, as long as there isn't a contraindication to a woman using hormones. And it's important to know that fibroids don't grow at a more accelerated rate under the influence of birth control pills, but on the flip side, nor do they control growth. Another treatment that actually works quite well at shrinking fibroids is something called a GnRH agonist. And this is a medicine that's given as an injection, and once it's injected, it lasts either for 1 month or 3 months, depending on the dose. And it interacts with structures in the brain to put a woman temporarily into menopause. So it decreases the message coming from the brain to the ovaries for the ovaries to make estrogen. Without estrogen, that mimics a condition of menopause, and the fibroids will get drastically smaller over the course of a few months. The problem is that we can't use it long-term because it is associated with osteoporosis. And so we don't want to treat one problem and replace it with another. So it's often used in a short-term situation. For example, if someone has large fibroids but wants minimally invasive surgery and she would be eligible for that if her uterus was slightly smaller, then that would be a good reason to use it. But you couldn't put a 45-year-old woman with heavy bleeding on it and say, all right, we're going to keep you on this until your natural menopause appears in the early 50s. Because during that time, you're doing damage to her bone strength. Now, women often don't enjoy being on this medication because it certainly does cause significant hot flashes and also some vaginal dryness. So women don't necessarily relish the prescription for a GnRH agonist. And the important thing to know is that as soon as a woman stops using it, the fibroids come back to the same size that they were. So there's no point in just using it for, say, 3 months if you don't have some treatment that you're going to do at that 3-month point. The last medical therapy that we use quite often is an IUD, an intrauterine device that has a bit of the hormone progesterone in the arms of the IUD. Now, IUDs are typically used for birth control, and they're very effective. But again, because the hormone progesterone can decrease heavy bleeding, IUDs can be a good option for women who have that symptom. In women who are using an IUD for birth control alone, their menstrual blood loss is 90% less than it was before they had an IUD in place. So it was based on that observation that we started using it in women with fibroids. But again, it's quite variable whether it will work or not. But some women can get a nice response to this and then maybe not need any other treatment beyond it. So really the holy grail is a long-term treatment specifically for fibroids. Birth control pills, the progestin-containing IUD don't treat the fibroids. They're basically treating the uterine lining and therefore trying to decrease menstrual blood loss. But the fibroids continue to develop and usually continue to get a bit larger as their natural history would suppose. So what has been in research and development for a number of years, many companies have tried to find a medicine that will block the effects of estrogen and progesterone on the fibroid, but not give the systemic effects like the GnRH agonist, in which a woman feels menopausal and then has the bone loss. So there are some compounds that are under investigation. I probably would have said 7 years ago in a similar talk that we were right on the verge of having a medical therapy, but there have been complications associated with this development, and they're not on the near horizon just yet. So then that leads us to talking about surgical treatments. And specifically, the surgical treatments are to remove the fibroids, which is myomectomy, or to remove the uterus, and the medical word for that is hysterectomy. And then depending on the size, number, and location, there are 3 different types of myomectomy. Making an incision on the abdomen, like a C-section cut, is called an abdominal myomectomy. If the fibroids are in the uterine cavity, then you can do a procedure where you put a long, narrow telescope into the uterine cavity and shave the fibroids off from within. And then more recently, laparoscopic myomectomies involve small instruments through the abdominal wall to remove the fibroids. So we'll talk a bit more about these. So this illustration again, showing where the incision is, low down on the abdomen. It usually is somewhere about 3 or 4 inches long. All of the fibroids are removed, and for example, you make a cut on the top and the fibroid shells out, almost like a hard-boiled egg. It's very firm and discreet. And then you put in stitches to close the space back up where the fibroids were. So this is really the standard operation for people who want to have kids in the future. Many times fibroids affect women who haven't completed childbearing, and a myomectomy would be the usual procedure for them if they have not adequately responded to hormonal medications. So this is a bit what it looks like. Here's some green towels around the uterus, but you can see these horns coming off, little bumps here and there, and then this is what the fibroids look like after they had been removed. So as I mentioned, hysteroscopy would be for fibroids inside the cavity of the uterus. These women typically would have very heavy bleeding. This is done in the operating room for the most part, and a woman is asleep. The procedure takes about 45 minutes. And this is what it looks like when we look inside, going through the cervix into the uterine cavity. You can clearly see these 2 fibroids, and an instrument goes through the hysteroscope that allows us to shave the fibroids completely out, completely down to the bottom, so that at the end, the uterine cavity would be free of these 2 fibroids. And lastly, laparoscopy. The incisions are typically made at the belly button and by each hip, often another small incision on the side rather than this one here in the middle. And laparoscopy is more challenging because what's so critical is that you sew the uterine walls back together where you've taken a fibroid out. So for example, here, it wouldn't be that hard to just cut across it and put a few stitches in right there. But when a fibroid is more embedded in the wall, then you need to be able to put lots of stitches in laparoscopically. And that's more challenging, and a tool that has come along that makes that easier to do is a robot. And so many people now doing laparoscopic myomectomies use a robot, which is a whole talk unto itself. But that robot allows the surgeon to put stitches in much more effectively and quickly. And so here's an illustration of what it might look like. These small, it's very much magnified. These are very fine scissors and grasper, and the fibroid is being removed from the wall of the uterus. Now, hysterectomy is another option, and again, this can be done through different routes, making a cut on the lower abdomen or an abdominal myomectomy. Vaginal is when the uterus can be removed through the vagina, or laparoscopic, the small incisions that I mentioned a minute ago. Hysterectomies are very commonly performed in the United States. It's second most common surgical procedure behind C-sections. It's estimated that 1 in 3 women will have had a hysterectomy by the age 60. Now, I think we're going to find that this number is decreasing over time as more options become available, like doing myomectomy. Basically, it used to be that if a woman had completed childbearing, she was told, you need to have a hysterectomy. And now many women in their 40s or even early 50s are opting for a myomectomy because they feel that their uterus is important to them. It's a structure they want to keep, even though they don't plan on having children. I would say that hysterectomy is reserved for women who either have a really extreme case of fibroids where they have so many fibroids that it's not possible to take out the fibroids, or they've had myomectomies in the past and the fibroids have regrown, or certainly women who say, I'm done, I'm finished, I don't ever want to have another period again, just give me the definitive treatment. So there are some different, within the category of hysterectomy, we can do an operation, an abdominal hysterectomy, so like a C-section cut or bikini cut on the lower abdomen. This is the uterus. This structure at the bottom is the cervix. We take pap smears right here of the cervix. A partial hysterectomy means leaving the cervix in place. And so a partial hysterectomy or supracervical hysterectomy can be done. We don't really know of any advantages to leaving the cervix. Again, some patients prefer to leave all the structures that are normal in place. Other times, if a woman has had abnormal pap smears, she should have her cervix removed to decrease the chance of abnormalities coming back and risking cervical cancer. But there haven't been shown to be any advantages to leaving the cervix. We had hoped that maybe it would provide better support to the bladder and vagina so that there would be less problems later in life in the 70s, 80s with relaxation of those organs coming down in something called prolapse. So it's something to talk about with your doctor about leaving the cervix or taking it out. Now keep in mind that hysterectomy means taking out the uterus. It does not mean taking out the fallopian tubes or the ovaries. And so for many women in their late 40s who are considering hysterectomy, they may be under the impression that hysterectomy means that they're going to immediately go into menopause because the ovaries have been removed. And in fact, that's not the case. The ovaries can stay just where they are, continue to produce hormones, and a woman will go into menopause at the natural predetermined age. But that can be something that she's thinking, oh, I don't want a hysterectomy because I don't want to take hormones or be in menopause. But with fibroids in particular, it's just the uterus that needs to be removed in most circumstances. So here's a total hysterectomy where just a little lower cut and the cervix removed. With a vaginal hysterectomy, the entire operation is done through the vagina. Speculum's placed in the vagina, and the operation goes up along the side of the uterus, and the uterus pulled down through the vagina. Advantage is that it leaves no marks on the skin. A requirement is that the uterus not be too large. If a woman's uterus is so big it extends to her belly button, that's going to be too big to get out vaginally. But this can be a very nice option. We think of this as the first minimally invasive surgery. Now, minimally invasive generally means laparoscopic, but gynecologists have been doing minimally invasive vaginal surgery for decades. And then again, laparoscopic, just as I mentioned, laparoscopic myomectomies. We can make little incisions. A telescope goes in, usually at the belly button, that allows us to see inside. Then surgical instruments go through small incisions that are usually 1/2 centimeter big. The uterus is separated from the structures that hold it in place. And then it's either pulled down through the vagina and stitches placed at the vagina, or the cervix is cut across and a machine comes in that cuts the uterus into smaller pieces to take out through these very small incisions. So there are lots and lots of gadgets. Often people say, well, I can see how you could cut the uterus away, but how do you get it out? And so there's something called a morcellator that cuts the uterus into smaller pieces in a safe fashion. All right, so let's just talk for a minute about the pros and cons of myomectomy versus hysterectomy. For many women, they haven't had kids or haven't completed their childbearing, and so a hysterectomy is simply out of the question. It usually is very effective for improving symptoms, and the uterus is preserved, so women retain that structure that may be important to them for their sense of being a woman. The disadvantage is that new fibroids can grow. A woman who has developed fibroids once, over the next 5 or 10 years, stands a good chance of growing new ones. Not that the ones that were taken out come back, but new ones develop. And unfortunately, we don't have a way of stopping that from happening. Now, the new fibroids may not cause symptoms, and she wouldn't need treatment, but it's estimated that within 5 years of having a myomectomy, about 10% of women have additional fibroid treatment. So that may require additional treatment in the future. It's a major surgery, especially when it's done abdominally. The hysteroscopy, the one that goes in through the cervix and into the uterus, is an outpatient procedure. People are back on their feet within a day or two. So if someone has a fibroid in that location, that's in some ways fortuitous because that surgery is more minor. Sometimes the uterus has been scarred a bit by having surgery on it and stitches in the wall of the uterus, so that women are encouraged, actually required, to have C-sections to deliver the baby. 1 week or 3 weeks before labor begins, before her due date, she has a scheduled C-section. So with hysterectomy, it's a guarantee. There's no uterus. Fibroids only grow in the uterus, so it's a guarantee that fibroids can't grow back. A woman does not have any more menstrual periods. Birth control is guaranteed. There is very high patient satisfaction, although hysterectomy gets a bit of a bad rap because it has been over-recommended in the past. Hopefully, it's not still being over-recommended. And it doesn't result in any changes to hormones. As I mentioned, the ovaries are not touched. Now, the disadvantages are that many women feel strongly that they want to keep their uterus for as long as they can. And that's just a personal preference. Again, it's a major surgery. There are certainly any woman who wants to get pregnant shouldn't consider this. And there is evidence that there are higher rates of incontinence and pelvic relaxation in the future, 10, 20, 30 years in the future, among women who have had hysterectomies compared to women who have not. So now we'll talk about 2 of the newer procedures for fibroids, and then do a bit of a comparison and wrap up at the end. Uterine artery embolization was first described probably in about 1995. We've been offering it at UCSF since about 1998. And the idea is that fibroids, like all tissue, need a blood supply to bring in oxygen and nutrients. And so if you could cut off the blood supply to the fibroids, they would shrink down. So this is a procedure that intentionally blocks the artery that feeds the uterus. That's why it's called uterine artery embolization. Embolization means to block the blood flow. So this is a procedure performed by specialists in radiology called interventional radiologists. And what they do is they place a little catheter or tubing into the artery of the upper leg. And they feed that catheter in through the artery, and they take quick little x-rays while they're doing it, and they can make it turn and go into the certain artery that they want it to, and they feed it into the uterine artery on one side, and then they pull it back and feed it into the uterine artery on the other side. And once it's in the proper position, they inject particles that are like grains of sand. And these grains of sand form a plug. It's intentionally causing a heart attack in your uterus. A heart attack is when the artery feeding the heart muscle becomes blocked, and this is blocking the artery that feeds the uterine muscle. Now, I think the proper term is uterine artery embolization. Sometimes you'll see it uterine fibroid embolization. They're really blocking the whole artery and treating the whole uterus, as opposed to being able to target just the fibroid. And this is important because it does likely have an impact on pregnancy. And so women who desire future childbearing should not have uterine artery embolization. There are centers where UAE is performed in women who have children planned for the future, but there are studies that show higher miscarriage rates and higher rates of inability to conceive. And so I think until we show that it does not impair fertility and delivery, that this should be reserved only for people who have finished childbearing. So here's an illustration of it when radiologists are getting started to inject the particles. First, they can inject dye that shows up as these dark squiggly lines. So this patient has a catheter in one uterine artery, ending right there, and on the other side, right there. So this is a big fibroid, way more blood vessel growth than is usually seen. Then after the particles are injected, it forms a plug so that blood cannot go forward into that uterus anymore. So it's quite dramatic. Now, along with that, there's some pain. I mean, just like in a heart attack, people have chest pain. Cutting off the blood and oxygen to the uterus results in some pain. These patients typically stay one night in the hospital for pain medication and then are out of work for about 10 days, sometimes 2 weeks, taking pain medicine, then taking things like ibuprofen. So there's no doubt it's a faster recovery than having a major operation, but it is not completely inconsequential. Here's another illustration, an MRI of the fibroid before the operation, before the UAE, shows this big, highly perfused fibroid. That's why it's so white. Here's her bladder. There's some contrast material down there. You can see quite squished again. Here's her normal uterus right here. And then over time, this fibroid is getting smaller. Now it no longer fills with the contrast material, so it appears dark. We see more of her uterus appearing. These images are bigger than that one. And then it's smaller and smaller still, and we can see much more bladder capacity to expand now that there isn't a heavy fibroid right on top. So an illustration of how the fibroid shrank over the course of a year following uterine artery embolization. About 90% of women have improvement in their fibroid symptoms, whether they have heavy bleeding or symptoms related to the pressure or the bladder dysfunction from the bulkiness of the fibroids. Now, the last treatment to discuss is the newest and probably the least really well known about and the least scientific information about. So from a physician standpoint, there really isn't good data yet on this device. It's called magnetic resonance guided, so MRI guided focused ultrasound. And here is a patient inside the big magnet of an MRI scanner. She's lying on her stomach. And here's the radiologist in their console, and they're looking at her fibroid images on the MRI machine. And then what happens is, coming up through a plate that she's lying on are ultrasound waves. Now, unlike the ultrasound used for diagnosing fibroids, these sound waves are focused. They come in at an angle and focus in one point in an area about the size of a grain of rice. And where all these sound waves comes together creates a great deal of heat. So where they're coming through and they're not yet focused into a point, that is not hot. That can go right through her skin without burning the skin or the tissues between the skin and the fibroid. But then it can burn a specific area within the fibroid. So she's lying on her abdomen, and these multiple sonications are performed over the course of a few hours. And this is what it looks like. Here's an MRI with this dashed line showing where the fibroid is. And then imagine that there were all these little grain of rice size burns to the inside of the fibroid. And then this is a map of the fibroid, the area that had been targeted. So in this case, just the center of the fibroid was burned. And then if you give a contrast material to show where blood supply still can go in the fibroid, you see that in the middle, now blood supply doesn't reach that area. So you've devitalized that inner part of the fibroid. So this is an FDA-approved technique. Over time, the FDA has allowed for more of the fibroid volume to be treated. At first they said, well, there might be some heat that goes to the nearby muscles or bowel or nerves, so you can just treat the inner part of it. But now with more experience, more of the fibroid can be treated, and so that may result in better outcomes. I think the jury is still out on how effective this is as a treatment. And here at UCSF, in the radiology department, they just were awarded a large grant that provided this machine to UCSF, and we're going to be starting to do some treatments and really studying how effective this new treatment is. So that's an interesting, exciting development. So in conclusion, I'll focus just on the three mainstays of treatment. Again, just comparing hysterectomy, myomectomy, and uterine artery embolization. This is the kind of thing that I talk with my patients about so that they're really clear on what the pros and cons of each one are. So the main drawback of uterine artery embolization is that I think it should be reserved for women who have completed childbearing. The recovery is much shorter. When hysterectomies and myomectomies are done with laparoscopy, the recovery is more like 2 to 4 weeks. So I probably should change this. This 4 to 6 weeks refers to recovering from an abdominal incision. We know now that after uterine artery embolization, about 25% of women go on to have additional fibroid treatments within 5 years. So 90% of women say that they're pleased with uterine artery embolization after 1 year, but only 75% are happy after 5 years. So some women did have symptoms come back. But we know that that's true for myomectomy as well. New fibroids can develop. And so really the definitive treatment is hysterectomy, and it's the right procedure for some people and not for others. So my advice is that you find a gynecologist who is experienced not only with talking about fibroids, but even more importantly, being able to offer you this wide variety of treatments. The treatment really needs to be individualized both for the size, number, and location of your fibroids, but also what your goals are, what life stage you're in. And so it's just far too common for me to see people coming for a second opinion who have been told their only option is hysterectomy. And it's really part of what motivates me to be a fibroid expert is that I feel like many women are not getting an adequate discussion of their options. So you should feel comfortable asking questions, feel that the communication style with your gynecologist is effective, or else go on the internet and find someone who might serve your needs better. Be sure to bring records, reports, notes from other doctors so that that consultation can be most effective. So just seek out a second opinion if you're not getting what you need from the first doctor. And then just a plug for the UCSF Comprehensive Fibroid Center here at UCSF. Thanks very much for your attention, and I'm happy to answer questions. Good question. So the question is, I mentioned that it's genetically based, and yet why do some women get them and others not? And really that's the black box. We know that the signal for a uterine muscle cell to turn on and begin dividing and over-secreting collagen and becoming a fibroid happens on the genetic level. Some gene turns on that really should be suppressed, and it results in that division and excess production. So that turn-on switch is what we don't fully know or understand. Once the fibroid begins to develop, we know that the fibroid needs estrogen, to some extent progesterone, to continue to grow. But what actually turns on that switch, we don't know. So we know that it's something genetic, but if you analyze the genes that seem turned on in one fibroid versus another, they can be quite different. So it's a vexing problem, and luckily some scientists are working hard at understanding that basic biology of them. So excellent question. Is there a way to prevent fibroids or prevent them from coming back? And I hope one day to stand here and say there is, but there really isn't. There have been there have been studies looking at things like diet or exercise, things that are within a woman's control, but they really don't seem to make a difference. Ultimately, there does seem to be an influence on whether a woman had children and at what age. Having pregnancies does decrease your chance of having fibroids at a later time, but it's not a strong influence since most people who have fibroids have in fact had children. But if you look at a population in general, so it's too bad, but we really don't know enough about the biology of fibroids to know how to prevent them. Question about fibroids in pregnancy and whether fibroids make it hard to become pregnant or pose a risk during the pregnancy. And it's really dependent, again, on the size, number, and location of the fibroid. So fibroids that are in the uterine cavity are probably the most strongly linked to infertility and problems during a pregnancy. And removal has been shown to decrease those problems. Fibroids very much on the outside of the uterus, on the other hand, don't affect getting pregnant or having uneventful pregnancies. And the fibroids more in the wall, it's harder to predict. So it's challenging. Some women, when they're pregnant, do have fibroid-related problems, but most do not. How are fibroids different from cancerous growth? So we know that fibroids don't spread beyond the uterus, so they don't metastasize. They expand within the uterine tissue as opposed to infiltrate into it. When I take out a fibroid, it's a very discrete, smooth ball that I take out, but the whole uterus is still present. I haven't taken out a big portion of normal uterus too. And so the way that a pathologist tells the difference is looking under the microscope at the tissue, and there are certain criteria for calling something a benign fibroid versus a malignant sarcoma. And thankfully, sarcomas are very uncommon. 3 out of 1,000 fibroids, quote unquote fibroids, do turn out to be sarcomas. But it's usually women in their 50s, 60s, 70s that have sarcomas. So if someone presents with a new fibroid or a rapidly growing fibroid in her 60s, that would raise a red flag. But in general, something that looks like a fibroid on an ultrasound or MRI does turn out to be a fibroid, particularly in someone in her 30s and 40s, which is the vast majority of patients who are dealing with these problems. So the question is laparoscopic or abdominal hysterectomy more preferable? And I would say that if laparoscopic or vaginal can be performed, that's preferable to abdominal. We think that there is less scar tissue that forms after laparoscopic or vaginal surgery. The recovery is faster, and there aren't significantly more injuries related to laparoscopic or vaginal surgery. So whenever the surgeon can do a laparoscopic or vaginal, that's preferable to abdominal. But sometimes the abdominal route is required because the uterus is just so big. All right, thank you very much for attending today.